Are you able to see my slides?
Yes, sir.
Okay.
Oh, we are live now, ma'am.
All right. So, can we have the display of the agenda and everything? Yeah. So, good evening and a warm welcome to one and all for the Thyroid Clinic session. Thyroid clinics, I'm sure everyone will be considering this as an informative session on thyroid health, both for the DM residents and for the general practitioners. So, before we start today's session, there will be a brief video of the Indian Thyroid Society, which represents the society's mission, its current efforts towards advancing the thyroid health. I request the tech team to play the video.
तस्य भासते सर्वमिदं विभाति.
Thank you for that. Now, the thyroid clinics, as we know, is currently being led by our distinguished coordinators, Dr. Pramila Kalra Madam and Dr. Roma Pradhan Madam. So we have our President of Indian Thyroid Society, Dr. Krishna Sheshadri Sir, Dr. Arun Menon Sir, who is the Secretary, and Dr. Mini Ma'am, who is the Treasurer. Their contributions have always been immense in conducting this program. We are also joined by the thyroid clinics team, Dr. Chitra and Dr. Vijay Reddy Sir as well. So, another short announcement before we proceed. Those who are interested to submit their research to the flagship journal of the Indian Thyroid Society, that is the Thyroid Research and Practice, can do so by scanning the QR code. And those who are interested to become a reviewer as well for the Thyroid Research and Practice can do so by scanning the QR code. This will definitely help you sign up as a reviewer as well. So, coming to today's program's overview, so our session today will include a case presentation. This is being presented by Dr. Kunal. He's the senior resident in the Department of Endocrinology at Ramchandra Institute of Higher Education and Research, Chennai. The case discussion will be moderated by the esteemed faculty, Dr. Sriram Sir and Dr. Vaishali Madam. Following this, we have an interesting talk by Dr. Bal Sir, followed by a quiz by Dr. Anusha at 8:50. So, moving forward, I'd like to invite Dr. Vijay sir to introduce the moderators for the case discussion.
Good evening. It's my great honor to introduce the moderators for the first session, going to be presented by Dr. Kunal Gupta, Senior Resident of Department of Endocrinology at Sri Ramachandra Institute of Higher Education Research. He'll be presenting on challenging labomas. So to moderate this session, we have Dr. Sriram Mahadevan, who is Professor and Head Department of Endocrinology, Sri Ramachandra Institute of Higher Education Research, Chennai. He's published more than 125 articles in peer-reviewed journals, nearly 20 chapters in textbook of endocrinology and diabetes. He's been awarded Honorary National Professor by the IMA College of General Practitioners in 2015. Next moderator, we have Dr. Vaishali Deshmukh, Madam. She is Assistant Professor, Department of Endocrinology, Sassoon General Hospital, BJMC, Pune. She is also Consultant Endocrinologist and Head Department of Endocrinology, Dinanath Mangeshkar and Deshmukh Clinic, Pune. And she is Gold Medalist, Proficient Woman Award, Kranti Surya Pratishan, and Jeevan Gaurav Puraskar, Adarsh Mahila Puraskar. So she is won many accolades. She is founder and secretary of NGO called Sphere. Over to Dr. Kunal Gupta to start this case presentation.
Good evening, everyone. I hope my screen is visible.
Yes, it is.
Yes, Doctor.
So, my name is Dr. Kunal Gupta. I'm final year DM resident in Sri Ramachandra Medical College. So, the topic I'll be presenting today is challenging labomas. So, the first case I'm presenting here is of a 30-year-old female who is married with 2 children. She presented with complaints of swelling over the neck for the past 1 year, which has been increasing in the size for the past 3 months. Patient does not have any compressive symptoms such as dysphagia, dysphonia, or breathing difficulty. Patient was clinically euthyroid. She did not have any comorbidities such as diabetes or thyroid disorder. Patient gives a history of papillary carcinoma of thyroid in her paternal grandfather as well as her paternal aunt. On examination, a nodule of approximately 3 centimeters in size was palpable in the right lobe of thyroid, which was firm in consistency. Other system examination was normal. We did a USG thyroid, which showed a 3.3 into 1.5 centimeters solid nodule, which was hypoechoic, taller than wider, with microcalcifications in right lobe of thyroid, with firm inconsistency, a TERAS 5 nodule. FNAC of right thyroid nodule was done, which showed a Bethesda category 5 nodule, suspicious for papillary carcinoma of thyroid. To summarize, this 30-year-old female with a family history of papillary carcinoma of thyroid presented with swelling over the neck for 1 year, with recent increase in size over the past 3 months. USG thyroid revealed a TERAS 5 nodule, whereas FNAC showed a Bethesda category 5, suspicious for papillary carcinoma of thyroid. Patient underwent total thyroidectomy with central lymph node dissection. So the histopathological examination showed a papillary carcinoma of thyroid, classic variety, which was multifocal, present in both right as well as left lobe. Tumor size was 1 centimeter in greatest dimension with no lymphatic invasion. Patient was planned for radioactive iodine ablation, prior to which patient was administered injection thyrogen, which was a recombinant TSH, 0.5 milligram, 2 doses, given 24 hours apart. Advantage of this recombinant TSH is that we did not need to stop hypothyroid medication prior to the radioactive iodine ablation, thus elevating the symptoms of hypothyroid in the patient. TSH was checked, which was more than 100. Patient underwent radioactive iodine ablation of thyroid with 100 millicurie of iodine. Patient was started on levothyroxine 100 microgram and was under the follow-up of an ENT surgeon. Post 6 months, patient was planned for a follow-up radioactive iodine scan, prior to which levothyroxine was stopped 3 weeks prior. TSH was checked prior to the scan, but was found to be undetectable. However, they went ahead with the radioactive iodine scan. Post the scan, the levothyroxine dose was continued as 100 microgram per day. So these are the labs. At baseline, TSH post-injection thyrogen was more than 100, with FT3, FT4 within the normal limits. A stimulated thyroglobulin was 33.81, with anti-thyroglobulin antibodies low. Patient at that time was not on levothyroxine treatment. Patient's TSH was checked at 6 months, 12 months, 15 months, 18 months. At all these occasions, it was found to be not detectable. Patient also underwent a radioactive iodine scan at 6 months, 12 months, prior to which the LT4 was stopped for 3 weeks. Even then, when TSH was checked, it was found to be undetectable. At all these occasions, FT3, FT4 were within the normal limits. Thyroglobulin was undetectable. Anti-thyroglobulin was also normal. All these was checked in the same platform as Siemens. Patient at all this time continued 100 microgram of levothyroxine. So we can summarize TSH being undetectable despite adequate dosage of levothyroxine. Thyroglobulin was not detectable. There was no sign of local or metastatic spread on iodine scan. A repeat USG at 6 months was done, which found no residual thyroid tissue. Patient was finally referred to an endocrinologist, and then the TFTs were repeated along with thyroglobulin and anti-thyroglobulin antibodies at 2 different platforms of Beckman and Abbott. We found that TSH, FT3, FT4 were within normal limits. Thyroglobulin was undetectable. Anti-thyroglobulin was also low. Since TSH in a case of follow-up case of papillary carcinoma of thyroid requires to be less than 0.1, the levothyroxine dose was increased from 100 microgram to 150 microgram per day. Now coming to case 2, we have a 50-year-old male with 2 children. presented with fever for 1 week, which was high grade, intermittent, associated with chills and rigors. Patient did not have any comorbidities such as diabetes or thyroid disorder, nor there was any family history of thyroid disorder. On general physical examination, an eschar was found at the left groin region. Patient's vitals were stable. Systemic examination was normal. As we found an eschar, a scrub IgM card test was done, which was found to be positive. TFTs were done as a part of routine biochemical evaluation. We saw that FT3 and FT4 were elevated, while TSH of 0 point was low. This all were done by CLI method. FT4, we've concluded FT4 was higher than FT3. Patient did not have any symptoms of thyrotoxicosis. TSH was not as suppressed as what will we expect at these FT4 and FT3 levels. Biochemically or clinically, this did not fit into the clinical pictures of grave disease or thyroiditis. We repeated the test within the next 24 hours by another platform in CMI method, and we found that FT3, FT4, TSH all were within the normal limits. So we had a similar case of a 2-month-old baby, which was found to have, undetectable TSH checked in the same platform at repeated intervals. For the patient, a whole exome sequencing of the TSH molecule was done, and that found a silent non-functional mutation of the beta subunit of TSH. We suspect a similar mutation in the case 1. It can be postulated that the amino acid substitution in the beta chain of the TSH has altered the epitope. This is preventing the binding of the monoclonal antibodies which are used in the Siemens immunoassay. Thus, its failure to recognize TSH in the serum. For the second case, we postulate there is an antibody interference. The heterophile antibodies of scrub typhus infections are interfering with the thyroid assay, resulting in high FT3 and high FT4 titers. We confirmed it by rechecking TFTs within 24 hours in a different platform, which turned out to be normal. So there are multiple factors that can interfere with thyroid assays. First, we have something called as macro TSH, which is something similar to macroprolactin, an inactive form of TSH. A monomer TSH forming an complex with TSH receptor antibody, which is clinically inactive. This will present as a falsely elevated TSH with normal free T3 and free T4 value. We all know biotin as known to interfere with TFTs on thyroid assays. With increasing use of biotin in hair products as well as in multivitamins, this biotin streptavidin complexes are a part of these immunoassays, and when excess biotin is taken, these biotinated products displace the complex, resulting in the falsely elevated free T3, free T4, and low TSH, mimicking a picture of thyrotoxicosis, and can result in inappropriate treatment. In the case of papillary sea of thyroid, this can show as a falsely low TSH. Thus, the physician can falsely reduce the dose of thyroxine. Heterophilic antibodies can interfere with TFTs, as is seen in a scrub typhus infection. Certain such drugs are such as aspirin, phenobarbital, carbazepine are also known to cause interference. However, the exact incidence is unknown. And in certain cases of paraproteinemia, these are caused to cause TSH assay interference. So I would like to conclude by saying that assay interference while measuring TFTs, especially free thyroid hormones, are quite common and should be always kept in mind when there's a discrepancy between a clinical suspicion or there's a discrepancy in the biochemical values. It is always prudent to wait and repeat the test in a different platform, and this can avoid unnecessary tests as well as investigations. Thank you.
Yes, Dr. Sriram, you can go ahead initially, the comments.
First of all, thanks to the entire Indian Thyroid Society team for giving us this opportunity, and thank you, Kunal, for your presentation. I would like to say that some of these cases were today it looks simple in a PowerPoint presentation, but when we actually dealt with them, real complex because we have at least 6 or 10 patients. Incidentally, everybody having scrub typhus. Scrub typhus antibody was somewhat similar to this wheel Felix reaction, is what we postulated. In our assay, in our college hospital, the free T4 was found to be very high with near normal TSH, not explaining the clinical picture. I would provokingly say here that in the last 3 months, we have had at least 2 occasions where when the TFT was abnormal, we diagnosed scrub typhus. I'm sorry, it is a ulta. In the sense, TFT was done in these patients more often because they are known hypothyroids. They wanted to check, and in one patient to rule out thyroiditis. Otherwise, somebody can question why in routine infections we don't, in an ICU patient or any sick patient, we don't do TFT unnecessarily. These were patients who were already either taking thyroxine or during the clinical picture, there was something which made the physician check. And when the lab value was abnormal, they called us. We have the Beckman-Coulter mission mainly in our hospital. Interestingly, in one patient, when we changed the platform, once we knew this phenomena, we changed it and it came the same. However, in previous 2-3 patients, interestingly, in the same Beckman-Coulter, when the patient recovered from scrub typhus, the assay was repeated and it was normal, which again goes to reasonably hypothesize that the antibody during the acute infection is probably interfering. So that's that much what we can postulate from these scrub typhus cases. Thereby meaning that, as was concluded in the presentation, in a given patient, when the labs are not correlating clinically and the usual feedback mechanisms are going haywire, it is always worth waiting and repeating both by a different platform, or very rarely, if you know that it is some infection related antibody, you can wait for some more time. This will be useful point in many of our patients. The other patient is very peculiar. The first child was a 3-month-old child, again 6 or 8-month-old child, failure to thrive, which was the pediatrician checked TSH and was repeatedly coming low. I would like to say here that this was one of the most famous corporate hospital in Chennai where the test was done repeatedly. That was Corona time, and they were the only hospital where the tests were done. The parents were repeating 3 times in the same lab. But when you change the lab, which means the different lab is using a different platform, the value became normal. Again, to show that antibody interferences are sometimes slightly more than what we anticipate. And in that case, we took the help of, I have to thank Dr. Nalini Shah from KEM Hospital. She was involved in the first case of that child, and we were actually slightly perplexed. The child was growing well, but still the TSH was low. 4 different platforms it was tested. Later, the parents were very anxious to confirm it genetically. We did the genetic test also. This patient who which Konal presented now, we are yet to do the genetic test. That proved that the TSH beta gene in that particular epitope was defective. Siemens 3rd generation TSH assay in a particular platform alone was not working. The other Siemens assays, Beckman-Coulter, the Roche, everything was normal. So again, as endocrinologists, we understand how much it is important to know your lab. I hope these 2-3 cases, though they are very rare, will exemplify the fact that we need to be aware of that and probably repeat in a different platform. Interestingly, what happens sometimes is they change the lab because the value is abnormal, but the other lab may also be using the same platform. So we need to check that the other lab uses a different platform before we conclude the abnormal assay. Thanks for this, and if there are any other further comments or questions, I'll be happy to discuss more. Thank you.
So I would like to thank Indian Thyroid Society for getting this interesting forum, because I think these lab related discussions are very uncommon in academics as well as in the, you can say, the society forum as such. Secondly, very few of us are really trained into labs where we know the intricacies of all the lab assays. Now, here, I one more point which I realized, Dr. Kunal has done an excellent job of taking us through the cases, but I feel that most of the thyroid cases actually are unfortunate that they are not able to come to us right at the outset. So they are usually managed, and then with somewhere in between, the endocrinologist comes into picture in such situations. So here I would just go through these two cases in terms of a clinical perspective from a private practitioner's point of view. So if you can just go back to the first slide of the case. Yeah, so please, yeah. Yeah, so this, as I can rightly see, and Dr. Kunal will agree with me, that this is a, what is the TNM classification for this? What do you think it is?
So, PTN,
No,
PT1.
I'm not talking about staging. I'm talking about the clinical TNM classification. What is your clinical impression in terms of where does this patient fall into? There is no lymph node metastasis. There is no distant metastasis. So N0, M0, right?
Yes, sir.
The tumor size is around 3 centimeters.
Yes, sir.
Yeah. So where does it fit into? It
It is
fits
less than,
into.
it's actually around 1 centimeter in dimension. So it's
Okay, just go ahead, please.
micro.
3 centimeters.
3 centimeters on examination.
Yeah, so even if you consider the clinical exam, I'm talking about clinical orientation to the patient. So into this picture, along with the ultrasound picture, we are confirming that it is a N0, M0 staging,
T1.
and it's a T2 nearly,
T1.
tumor stage 2. So do you think that this has been the right modality for treatment for this patient? I differ on the, just go ahead. Do you think a central node dissection was indicated in this patient? Of course, the surgeon is operated.
May-
So,
There is a
what
small
is the
hitch
role of
here.
central?
Sorry to interrupt. These patients were operated by our other colleague in a
Yeah,
different
I know that. I'm asking
Only
his
when the
opinion.
PFTs are abnormal, they were referred to us. Initial management are all done in a different corporate hospital in Chennai.
I'm giving a perspective for the students, sir. I'm not talking about your
No. Just, yeah. Sorry. Thank you.
I'm asking his perspective that if
Yes,
this
ma'am, it was
patient would have
not,
presented to him at the outset, would you do you think that the central node dissection was the right decision taken?
it was not required, ma'am.
So would you do it in this patient? What would be your strategy had the patient come to you with this clinical diagnosis?
I would have gone ahead with a total thyroidectomy,
Mm-hmm.
but with I would have preserved the lymph nodes.
Yeah, that's right. And secondly, this next slide, you think that thyrogen is needed for every patient? I'm sure Dr. Bal will tell us better on all this, but what is the routine practice? Is thyrogen given to all malignancy patients?
No, not happening.
As this patient was affordable and
It's okay.
patient did not want to, we could have avoided the hypothyroid symptoms. So in this case, we had given thyrogen, but routinely because of its cost.
Dr. Kunal, please clarify. We didn't give. This
We
was
didn't
all
give. We didn't give. It was given outside. Probably.
We reviewed the TFT after a year and we found out this extra problem.
I'm
How
assuming
many
because
nodes
it
were
was-
involved? How many nodes were involved?
lymph nodes were not involved.
So, but you have written stage 2, go back to PT1B. You have written, go back. Yeah. Where is the staging? Yeah, you have written 1A, N1A means how many nodes positive? N1A means nodes positive. How many nodes?
You didn't collect the information?
This lymph node.
Dr. Bal, can you just throw some light on thyrogen use?
Yes,
Because I
it's
think
been
that
very, if you, this is a classic case of mismanagement and a lot of things we are talking, which would have been avoided. This patient had, I don't know how many nodes are present, but it was clinically, radiologically was N0 neck. And then they did a total thyroidectomy for a 1 centimeter tumor, which is very In today's era and time, it is not acceptable. If there is any clinical, radiological on table, if you find node and the on table, if you find the nodes are positive, you can go ahead and do the neck dissection, central compartment dissection. That is fine. Okay. If they say okay, one node or two node is okay. But again, giving thyrogen and then giving radioactive iodine, all these are over treatment for these patients. And then when the T3, T4 were within normal limit, what we are trying to, why we are trying to increase the dose of thyroxine? Are we treating the lab report or we are treating the patient? Even in the second patient also. I am telling the first thing what we are forgetting about that, whether it is endocrinologist, nuclear physician or surgeon or corporate hospital, private practice, doesn't matter. The basic clinical management, the patients to be evaluated. If patient is euthyroid, you don't have to run around and trying to do 20 things for, we are not treating the reports, we are treating a human being. If patient is absolutely normal, if the report comes, verify in some another time, another lab and get it verified. But that's the only thing to be done, not trying to do everything and trying to give thyrogen, trying to give increasing the dose. For what? Are we managing thyroid cancer or we are trying to kill the patient by giving excess amount of thyroxine? Anyway.
Anyways, but I think we have DM students, so I think for their benefits, can you just help us where you would really use thyrogen? Because I have
Yes,
not,
we
I've used it
only
only for two
indication.
patients in my lifetime.
The
So
absolute
I'm-
indication, indication of thyrogen is when the PSA patient has got hypopit, he or she cannot mount the TSH response. That is the only absolute indication. All other indications are you travel by a train or you travel by a economy class or you go by first class, all your convenience. That is not my. If they want to go by thyrogen and that is fine. That is your problem. It is academic. That is not convenience, matter of convenience. Only
I
absolute
can share
indication
my two
when.
experiences where I have used it. One is in a spine metastasis where this person had a precarious spinal mets where we were fearing that waiting for 3 weeks would actually
Ma'am,
cause
that is a
everything.
contraindication for any spine or brain metastasis giving thyrogen. You are actually jeopardizing the
Yes,
patient.
but this was a patient of CA thyroid who was operated, and after that we could not wait for 3 weeks.
No, it's okay. What you can do in that case, if there is impending paraplegia or expected to have the worsening of the nerves, you can give external beam radiotherapy, which is a standard form of treatment, and then you can give iodine later. It's not necessary. In
This was
thyroid cancer,
suggested
earth
by
is
the
not going to shake.
oncologist, so that
The
was
earth is
the
not going to shake if you delay the treatment by 1 month or 2 months, by 6 months, doesn't matter. In closed compartment, whenever there is a metastasis, whether in the brain or in the spinal cord, in fact, in the booklet of thyrogen says it is contraindicated because it worsen.
So this was a
Benefiting
patient
to
of
it
a large
worsen.
the papillary thyroid with lung metastasis and bone metastasis, and
That's
we had
fine.
to
That is
give, yeah.
that is fine. That is what I'm trying to say.
And second
In a
patient, I
closed
had a
compartment,
patient
you are
from
supposed to avoid. In a closed compartment, you are supposed to avoid. Because that worsen, because
I
certain
agree with
size
you,
of PSH
because
going
there is
200,
likely to be
300, it
worsening
will
of
worsen
the
the condition.
size and increase. That's right. So that is a contraindication that the metastatic size can increase. But
Yeah.
this was one of the patient where we had used. And second was a patient who was going to travel to the US and had no insurance covered there. So
Okay,
he was not going to get.
I have also treated patient called 10-day protocol. I have treated several patients. One Singapore Airlines air hostess, she told if I don't join by 10th day, I will be terminated from the job. And so we did the operation on 48 hours later. We give the recombinant TSH for first injection on 96 hours. We treated the radioactive iodine, and on day 7 she was discharged and gone, and she's fine for last 25 years. That's fine. Those are for matter of convenience. I'm not talking. The routine matter is in India, 99% of the thyroid cancer are managed with non-thyrogen.
Yeah. So basically, thyrogen indication is what it needs to be very specific. So I don't think wherever this patient was treated with thyrogen.
No, in India, if you have the money, you can get anything you like. You can donate a jet plane to your husband on a bad day.
Okay. So, anyways, so this case, the next case I wanted to know that if the patient did not have hyperthyroid features, why was TFTs done in the primary this thing? Because the second case, why would one do a thyroid function if you are not suspecting?
Certain times we found initially that when they were admitted in department as a routine part of biochemical investigation, they are being over.
Because I've seen that there are a lot of errors when you do it in an infective patient. So all the thyroid assays are quite erroneous, and we usually avoid any critical illnesses or in febrile patients unless you're suspecting thyroid. So where do you really suspect endocrine fevers? I don't know. Because here, what are you suspecting in terms of, are you suspecting any endocrine cause to the fever? That's why you did the thyroid function. What is it?
No, ma'am. Actually, these patients we got a referral from the medicine department.
Okay,
They
okay.
were-
So medicine people have done it as a
Overzealously, TFTs were being done, and then we noticed a pattern that these TFTs with elevated FT3, FT4, and non-suppressed TSH, and later they were found to have scrub typhus. So
Okay.
then we found a pattern that in some patients, when we found this TFE, we retrospectively did a scrub IgM and we looked for an SCAR, and we retrospectively diagnosed patients with scrub typhus.
They are
with
all
this-
heterophil antibody interfering in the assay. That is
But
also-
won't you really suspect thyroiditis in this patient? Asymptomatic thyroiditis.
With the,
What has been done for that?
the TSH was not at 0. With this level of FT3, FT4, the TSH is
That's
not
usually
suppressed.
what you see in what is Hashimoto's. You see the same, right? That's what we commonly come across. Thyroiditis, the recovering phase of thyroiditis,
But if you
subacute
do a
thyroiditis.
TPO antibody done, you can diagnose within two minutes what is Hashimoto's thyroiditis. So you don't have to
So
worry. about it.
actually, I'm confused. Which
Only one,
report is the right one?
which
The
you will
first
have
one or the
difficulty
second
in
one?
only one which you will have difficulty in diagnosing is viral thyroiditis or decurrence thyroiditis, where there will be antibody negative, but the feature
PSR
will
and
be same as
CRP will be high. So I don't know the.
So if you Hashimoto's thyroiditis can easily diagnose by doing anti-TP antibody.
What was the status of ESR, CRP, anti-TPO in these patients?
This patient has fever,
ESR was
any
elevated,
cause of
ma'am.
ESR will rise, so
Yes,
that will not have any
since-
discriminative power. That will not have any discriminative power.
Yes, ma'am. ESR was elevated, but since the patient, as I said, is
He
fever.
has got fever, patient has got.
And what about the antibody status, anti-TPO and?
Anti-TPO bodies, actually, we did not ask, ma'am. Again, in these patients, anti-TPO.
No, I think what I want to ask you is that how do you really confirm whether this report is wrong or the second one? That is what is my concern. Because if everything was normal, say anti-TPO was normal and the CRP was, then I would have
patients,
taken.
we
what
did
you
a
said.
TFT after the scrub typhus infection resolved, which was
Yes,
found to
sir.
be
Yes, sir,
normal.
please.
Yes.
Dr. Sriram has to say something.
No, he put up a patient where this TSH is slightly 0.1 and giving the picture of a thyroiditis. But I was mentioning that we have a series of now 7 or 8 patients where the TSH is bang normal like 3.5 or 2.8. The picture was more like a resistance to thyroid hormone or a TSH secreting condition, which are extremely rare in an acute. We don't consider those possibilities. So when the T4 was sky high, it was above the limits of the lab. So that is where you obviously, I mean, first look as an endocrine person, I know that there is a lab phenomena, but it was curiously getting associated in a pattern of 7-8 patients with scrub. So we thought that, okay, as Sir was also pointing out, that was the heterophil. Initially, we didn't do it in 2 platforms. We followed up the patient, repeated after 6 weeks and 12 weeks, it recovered. Again, going to say that the antibody as it comes down is making the thyroid functions normal in the same platform. Later, we found out that in particular platform it is there. So it is a mixture of everything here. I agree with you.
That's exactly what I thought, that it's a mix of typhus, the antibody interference, plus thyroiditis, plus a probable element of CQ thyroid syndrome also coming into picture, all put together. Only CQ thyroid syndrome doesn't explain the high FT3, FT4. Otherwise,
with 1 week,
with 1 week,
ma'am, with 1 week fever, it is not CQ thyroid syndrome. CQ thyroid syndrome occurs in ICU setting, where the patient
not necessary, sir. I think I disagree with that, because any febrile illness patients can come with CQ thyroid.
No, it takes time, ma'am. The T4 to get convert, T4 has
in
got
fact,
half-life
COVID
of
was
7
the
days.
classic scenario where we saw that. COVID was the
COVID is a once in lifetime. It's not, COVID cannot be taken as for everything. COVID is a lifetime, once in lifetime. In ICU setting, when a patient is prolonged in ICU, we see, because this is a thyroid economy, the body tries to down-regulate the 5' deiodinase, so the T4 doesn't get converted to T3, so the
Isn't
metabolic
that true
rate of
for
the
all
patient
illnesses,
improves.
sir?
No, that is body's coping mechanism. No? That is body's
That's
coping
what I'm
mechanism.
saying. So it is true for
But
all.
not for a fever of 1 week. That is not the argument. Any fever comes with 1 week and you say it is a CQ thyroid syndrome is not the accepted argument.
Anyways, so take home, I would say for this case would be that any sick patient, it's very difficult to interpret TFTs. So it is better that things are done only when really suspected. And when you're suspecting a storm or suspecting a myxedema crisis, I think otherwise the normal policy that we follow, even in ICU, I usually tell my patients that the doctors that you don't do any TFTs in a critical ill patient, in a sick patient, unless you're strongly suspecting thyroid dysfunction or you are having a goiter. So I think this is one point. Probably both these cases tells us what not to do better than what to do. And secondly, I think that these are very practical scenarios.
The second patient actually teaches a lot. The second patient teaches that one has to be always careful about the assay interference, which is lab errors are much more common than actually a patient has some problem with the patient. That is the point, teaching point from these two cases. And then first case, the thyroid cancer, actually we over-treated this patient, which doesn't require. You had no fracture, you are trying to put a nice plaster and saying that after the X-ray is no beautifully healed bone.
As far as my experience goes, subacute thyroiditis and Hashimoto's thyroiditis, I've seen these kind of presentations coming in them. So usually I do not repeat the lab immediately unless repeated labs are showing the same. So repeated labs showing that with change of time. So I would not repeat it in 24 hours because anyways, there's no hurry of treating this lab also when the patient is asymptomatic. You can just wait and watch. So a 15 days of wait and watch policy would have helped for this patient rather than spending more, because I think even if the second report would be erroneous, you are not able to judge what is the reason for it.
True, agreed. That was the main point we presented this, how in a practice sometimes we get confusion.
That's right. That's
No,
right.
no,
we are
Dr.
learning
Sriram,
more.
So well presented.
Dr.
And I
Sriram,
think
detecting
very-
heterophile antibody is not a rocket science. Just put a blank assay and you will get the heterophile antibody titer immediately. It's not a rocket science.
One more
Just
point
talk
which
to
I
any lab
thought
people.
was
You talk to any
essential.
lab people, you say I am expecting a heterophile antibody, they will put a blank and they will get the assay positive report showing that. This is not a rocket science. So because we are not now trained with the radioimmunoassay, the techniques and lab and other thing, hardly any endocrinologist is going to the lab now. So that is different.
One point I wanted to just make before I stopped my discussions on this, but that a lot of our patients in such scenarios are on polypharmacy. So they are on steroids, they are on antibiotics, and they are on many drugs, even cardiac drugs most of the time. So I think that also needs to be one of the points which you have rightly mentioned, Doreen, in regards to the drugs. But that needs to be put up into these cases whenever you are presenting these cases. What were the drugs given to the patient along with this also would make a lot of difference to the presentation and interpretation of these assays. So I think that these cases are worth discussing for an individual symposia. You can say that they can open up huge discussions, but I'm glad that we could talk on this and we could get some, you can say, eye-opening thoughts and some perspectives into this in the clinical practice. So I hope that I am not exceeding the time. So Dr.
Thank you, madam.
Reddy,
Thank you,
I'm
madam.
thankful for inviting me here. And it was a good learning for me too. Thank you so much.
Thank you, everybody. Thank you.
Thank you. Thank you so
Thank
much.
you, Dr. Sriram and Dr. Vaishal, Dr. Kunal Gupta for having presented this interesting, challenging labomas. So next we move on to the monologue for today. The topic is, do one need nuclear imaging of the thyroid gland in the era of the ultrasound, CT and MRI? It's going to be presented by Dr. C.S. Bal, who is Professor and Head Department of Nuclear Medicine, AIIMS, New Delhi. And he has got multiple achievements to his credit. First to start DM in therapeutic nuclear medicine. He's a pioneer in low-dose iodine-131 ablation, DTC. He's introduced the concept of lobar ablation, established clinical dosimetry in India. He's ex-president of Indian Thyroid Society and ANMPA. Over to you, sir.
So can you just put my slides? They are my slides. Okay, thank you, the Indian Thyroid Society, and thank you, Ganpati, for this invitation. And many a time people say really nuclear medicine people are required to do any thyroid imaging. I think I partly agree. We do over imaging. And when it would be useful, I am just going to give a bird's eye view shortly next 20-25 minutes. Let's hope. Do you need the imaging in this patient? You can look at the patient, you know the diagnosis. You don't need any imaging, In fact, when the endocrine surgeon or a head and neck oncologist or a ENT surgeon wants to operate, he may do for staging, restaging, seeing the vessels, how much involved, whether it will be operable or inoperable, or nodes are there or not. For that imaging, but thyroid imaging is not required. You can know the diagnosis written on the head. It is a long-standing thyroid nodule with a skull metastasis seen. And if you get a thyroglobulin down, it will be in hundreds of thousands. So as already we had a lot of discussion about how the thyroid function works, and then we have a sodium iodide symporter, and that is the molecule which allows the iodine to enter. So there is a functional imaging we do, and that is a this was in 1996. Nancy Carrasco discovered this molecule called sodium iodide symporter, and this it is present in the thyroid. It is also present in salivary gland. It also in the lactating breast, and it is a very big molecule. It is a 13 cross across the cell membrane. It is a cell membrane bound protein which allows the iodine to enter into the cell in exchange of sodium. So indication of thyroid imaging, metabolic status of the patient. First I was again and again emphasizing, whenever a thyroid patient comes, please examine it. Don't look at the lab reports. Look at the patient's, what is his metabolic state, whether it is hypothyroid or euthyroid or toxic features, whether the gland morphology is a multinodular gland or solitary thyroid nodule, diffuse enlargement. Sometimes patient can have a non-palpable gland. Or when there is a suspicion of malignancy, there is a neck mass, post-surgery evaluation, post-therapy evaluation. These are the setting in which patient comes to you. And then it was the first history of nuclear medicine, Benedict Casson, and this was and Benedict Casson discovered scintillation counter, which is hardly now used. Hallanger is the man who discovered in 1958. Then we have this imaging good old. If you look at the many of the thyroid institutions where these type of scans are, but these are now mostly in the Jurassic Park era. You can see this classic Graves' disease. You don't need any imaging. You just look at the patient. The diagnosis is written on the face and the eyes. So what is this? Sometimes you can have a feature like there is a multinodular gland in the background of multinodular gland. Sometimes you want to take a biopsy, whether which one to be FNAC and which one you want to stick the needle. Sometimes you need some imaging. You have to identify, or now you can do ultrasound guided. If there is a vascular nodule, you can put a needle there and make the diagnosis. And here is look at this girl. So if you look at the patient, classically Graves' disease, but look at the scan, it is a multinodular gland. Sometimes the scan and the photograph, they do not match. This is a classic Graves' disease with unilateral ophthalmopathy, and there is a multinodular gland. These are the retrobulbar metastasis. Even in the unilateral exophthalmos, commonest cause is Graves, but sometimes you must not forget that could be retrobulbar metastasis which can produce exophthalmos. That we must keep in mind. Then this, what is the abnormality in this 42-year-old? You can see there is a very smooth increase in the neck mass. There was abnormality in the eye. You can see the right eye is bulging out. Then this patient CT scan was done, and you can see there is a retrobulbar mass there. And then what was the diagnosis? So there was somebody did a Dotanox scan also. You can see there is a mass which is Dotanox concentrating. It is a somatostatin receptor expressing tumor. So what is the diagnosis now? Still not. 42-year-old female. So this is somebody did again PET scan. Nowadays, everything you can do. There is a big mass in the neck, and that mass was already very high FDG avid mass. So that now you know there is a possibility of a lymphoma, or it is a advanced thyroid carcinoma. And we did iodine scan. Even in the intact thyroid gland, we can see the iodine scan, give the tissue diagnosis. So it is all the other scans, whether it is a somatostatin receptor-based scan or a FDG PET scan. Nobody could give you tissue diagnosis except a standard radioactive 2 millicurie radioactive iodine scan in spite of intact thyroid gland. So sometimes they are very functioning tissue, you can demonstrate them. So this is STN in a Graves gland needs imaging. Like this lady has got a thyrotoxic patient with a nodule, and it turns out to be papillary thyroid carcinoma, FNAC left lobe nodule, focal nodular hyperplasia, HP follicular thyroid carcinoma histopathology. So in this patient was after how many years now? Between 2006 and 99. So 7 years later, this Graves gland was given radioactive iodine in another center, and this actually harboring a papillary thyroid carcinoma, which was later diagnosed. So thyroid carcinoma coexists with hyperthyroidism. That you should not forget. Follicular variant of PTC is a thyroid nodule in this patient. This is from a man from Northeast. After total thyroidectomy, you can see how much thyroid gland is left. So you have toxic multinodular goiter, euthyroid MNG, you have got all these are needed. Sometimes you want to do which nodule to be biopsied on for that purpose. Otherwise, there is no need of doing. STN with toxic feature needs imaging to rule out FTN. Now, this patient was got hyperplastic nodule, 2 hours uptake 17%, 24 hours just increase, but the thyroid gland is still not suppressed. This is a evolving FTN. In such cases, you can find T3 was 367, T4 was 13.6, TH was 0.2. This is a biochemically toxic, and the thyroid scan shows a evolving FTN. Such nodules. Here, you don't need, it's eloquent. You just look at the scan, you know the diagnosis. You don't have to bother about it. In children, hot nodule harboring PTC in a 6-year-old girl, you can see the thyroid scan. That hot nodule is nothing but a papillary thyroid carcinoma. And you can see another young boy, 5-year-old. Actually, his nodule was seen when he was born, and at the age of 3.5 years was seen by many pediatric endocrinologists. Finally, this boy was referred from Jaipur to at the 2 months age. Since 2 months of age, somebody did a thyroid scan, and it was a hot nodule. And it turns out finally at the age of 5 operated, it turns out to be a papillary carcinoma thyroid. So we have now more than 20 kids with hot nodule, which are all turns out to be papillary thyroid carcinoma. So we have published it and demonstrated that if you get a hot nodule in less than 10-year-old, must rule out malignancy. Is another girl, you can see. This all histopathology and everything is concordant. Here you can look at the image and you know the diagnosis. This is McCune-Albright syndrome. You can see there is the GS alpha mutation that has occurred, and you look at the face of the patient, you know the diagnosis. You did the bone scan, you did the thyroid scan, you can see there is autonomously functioning nodule with bone fibrous dysplasia, you can demonstrate. So we have a 4 category. You can see very clearly the upper left is the Graves gland, which is uniform distribution increase and the suppression of the salivary gland background. Then we have got toxic FTN on the right, then viral thyroiditis on the right lower, and the toxic MNG on the left. So all these variety, you can just look at this scan. It takes 2 minutes to make the diagnosis. It is not rocket science. So here is a toxic patient with right STN. So if the patient is toxic biochemically and has got STN, you will put that you thought it is a FTN. This patient was operated. After operation, the patient was referred to us because patient T3, T4, TSH was all in toxic range. Patient was referred from Northeast to AIMS. And you can we did a technetium whole body scan. You can see how much metastasis, functioning metastasis in this patient. All bones, many of the bones, lungs, everything was, even they have taken out the nodule, is a functioning thyroid carcinoma with distant metastasis. This is the FDG PET scan showing all these lesions. So there is a mixed lesion. There is some of the lesions which are FDG avid, and they are less uptake in iodine, but some will be. These are the mixed type of response we expect in the future. And this is the final diagnosis. Is a functioning well-differentiated metastatic follicular thyroid carcinoma producing hyperthyroidism. So thyrotoxicosis is the cause because of the distant metastasis functioning, producing enough hormone and keeping the patient toxic. So here is the development of toxic MNG in last 6 months, subcutaneous nodule. You can see there is a chest nodule which is being in technetium scan. You can see the technetium scans is all functioning nodule. This is toxic. When you this tox patient is toxic, and you do a technetium scan, you can see the distant metastasis, lungs, nodule, lymph node, and even on this cutaneous nodule all are positive. So this is the MNG of particular thyroid scan and versus FDG. You can see this patient has got thyroid. Left hand side is a technetium scan, whole body scan. Right hand side is FDG. You can see there is a same every lesion here. So they say if you have got FDG ability, iodine and all will be negative, but this is not the all the time possible. Is a called flip-flop phenomena. When there is a tumor get differentiated, is FDG is high and they don't care. This patient was operated, treated and doing well even after how many now? This patient was treated in 2007. After 18 years, patient is still alive and doing well. So this is another patient with a hot nodule. You can see the scan. There is a big nodule which corresponds to this, and you can see the lung functioning metastasis in the lungs. So if you see T3, T4 high in a nodule, that doesn't mean that it is FTN. You can sometimes there will be a functioning nodule with metastasis can also produce similar feature as FTN. So the classic cold nodule, you can see a cold nodule in the right. Another patient is can see intrathyroid nodule. You can have a big nodule also extending up to the isthmus. You can get in children in a malignant nodule, you will be have uptake. Initially, there will be increased bloss and gradually disappear, become cold. So this is typical malignant nodule, which will have increased arterial bloss followed by cold nodule. Whereas a FTN will have initially slow uptake, and so this is how you can just do a 2-minute dynamic scan. You can separate one from the other. In hot nodule, which is FTN, which will have initially slow uptake and gradually increase in the collection of tracer, whereas a malignant one will be increased arterial blood supply, so there will be arterial bloss, and after some time it will be cold. So this is how classically you can differentiate malignancy. Even without sticking the needle, you can make the diagnosis. Here is another patient, is the cancer diagnosis possibly for surgery by thyroid scan. You can look at the patient with intact thyroid gland, and you can see the lung metastasis FDG PET scan, and you can look at the technetium per technet scan showing all the same lesions. So there is this so-called flip-flop phenomena is not always correct, which is been overpushed by many of these people. You can also sometimes see the functioning neck nodes. You can see this patient has got a multinodular gland with multiple neck nodes. You can diagnose them very well. Even the axillary node, the channel retrograde flow of the lymphatics going up to the axillary node also you can demonstrate. So two classic Graves' disease, post-radioiodine nodule becoming prominent. You know the diagnosis now very well. This is the classic diagnosis of a nodule. When the gland is hot, the nodule is cold. But as you give radioactive iodine, the gland will be cold and the nodule will be hot. Marie-Lennard syndrome. And then you can make the diagnosis very well. This is all the spotter. This is all the viral thyroiditis. Patient may have pain, tenderness, or history of URI for a few days, may not have tenderness sometimes. You can do a thyroid scan. T3, T4 will be high, TSH will be low. And if you do a particular scan, you can see nothing in this neck. So this is the acute phase of the viral thyroiditis or decurvence thyroiditis or subacute thyroiditis. And you allow for a few weeks to few months, they will all recover back. In fact, sometimes they go to a hypothyroid phase and then recover back to normal. 98% of they become normal. So you can sometimes there is this young girl had a red bulb on the back part of the tongue, and you can see because they are iodine containing tissue, you can do even a CT scan, you can diagnose this is a lingual thyroid gland, which is the only thyroid gland present in this girl. There's another one, which is you can look at this upper part of the neck, just below the chin. This is the only thyroid gland that is the present. So this is undescended thyroid gland, not separated, differentiated into two lobes. It is just a bulb mass. And if you take it out, so it will be all gone, and the patient will be on thyroxine for the rest of life. So sometimes how it helps in diagnosis, you can look at this picture and you know the diagnosis. If you are a very astute clinician, This is a preventable cause of mental retardation in India. You can give a pinch of thyroxine, and the patient child would have been normal. You can see this. This is a small lingual thyroid gland in the neck. Rest of the neck is clean, nothing. So this is a patient who has got 11. By the time he came to me, he was 11-year-old. It's in some 23 years back. And we started on thyroxine, but anyway, the somatic growth will improve, but the intellectual activity is gone. So these are the another cases, this lumpy, bumpy. You can see, you look at the tongue and the diagnosis written. This is a 2 hours uptake is 15% and 24 hours it's a rapidly discharging gland. This diagnosis of dysharmonogenesis. So this is a follicular variant of Pattis in a dysharmonogenetic gland. You can see this harmonogenetic gland, and after the surgery, the child is grown very well on thyroxine. This is a multinodular goiter in a 5-year-old, and this to be removed, and the patient will have better quality of life if you put them on thyroxine. So this is another patient with lingual thyroid having PTC in a lingual thyroid. She just came last week. She is now my 35 years of follow-up. She's doing extremely well. She was given a doctor. There is another patient with a malignancy in the thyroglossal cyst. Then we can do what is the diagnosis on this patient? Is very classic hockey stick sign, which is a hemiagenesis of the right gland. And the left and the isthmus is there. So this is called classic hockey stick sign. This is a hemiagenesis. So thyroid imaging, thyroid cancer, pre-surgical evaluation, post-surgery assessment of remnant or METs, post-therapy scanning of the resting, restaging, assessment of radioiodine ablation, restaging when clinical, biochemical, or radiological suspicion of recurrence. There are only these 5 indications. Pre-surgical evaluation, the evaluation is very less now because we have all the modern gadgets. Post-surgery assessment of remnant and METs, definitely for METs, for remnant, yes or no. But post-therapy scanning for restaging is very little used. Assessment of radioiodine ablation, you can do it thyroglobulin, you can do it thyroid hormone stimulation. But if you do iodine scan, that's fine. Restaging, of course, yes, when there is a clinical and biochemical radiological suspicion of recurrence. So this list has been once several times to be the gospel. Now there is a lot of modification in this list. You have a 25-year-old female patient with lower socioeconomic status, presented with a left-sided thyroid nodule for 6 months, on examination form, non-tender, 2 to 3 centimeter size with palpation, cervical nodes, and ultrasound left solid nodule 2.5 centimeter, and large bilateral nodes, FNAC papillary thyroid carcinoma, chest X-ray and chest CT scan were reported normal. Patient underwent total thyroidectomy with central and bilateral neck dissection at a private nursing home on October 2012. Histopathology were 2.2 centimeter right side nodule, PCT classic, 6 out of 14 nodes positive. None of the nodes were more than 3 centimeter. So it was PT2N1B and MX. Patient developed severe hypocalcemic tetany in post-operative period requiring 4-hourly calcium gluconate IV infusion. And this is the chest X-ray, this is the CT scan. And when we did the iodine whole 2 millicurie iodine whole body scan, you can see there is even after so-called total thyroidectomy neck dissection, you can see plenty of neck nodes, plenty of residual thyroid tissue, and as well as bilateral lung uptake, which are the CT as well as the chest X-ray was normal. If you would not done the iodine 2 millicurie scan, you would not have extended the disease. Even if you done the thyroglobulin, but you will not know where it is coming from, you have to do an iodine whole body scan to assess the extent of disease. Now this patient has got neck nodes and lung metastasis, which is X-ray negative, which will have very good outcome. Now this is the patient, 150 millicurie. We had given 6 doses, 900 millicurie total cumulative dose, and after that patient is completely disease-free now from 2012, and another 13 years now. Patient is fine. So sometimes in a 26-year-old, the PCT PT2N0MX is done from Guwahati, and you can see the scan was done. But something was missed in this scan. And when this patient came was for thyroid remnant ablation, so we, as usual, we give 30 millicurie. So when we did the 30 millicurie, and this was in 2009. So we did the scan, and you can see there is a remnant very nicely seen. What was seen in the diagnostic scan, you can see. But I found something in the central part, which is, I asked about her periods, menstrual cycle. She told, no, we don't have any, it was only 15 days back. So we thought, why a central part? So I did, as expected, I did a CT scan. I didn't find anything. Then I did a SPECT CT. You can see there is a metastasis in the sacrum, in the bone skeletal metastasis in a 26-year-old without neck nodes. Classic present of iodine concentrating metastasis in the sacrum. Sometimes you get abnormality. If you don't have done this scan, you would not have diagnosed that. Then this is a 25-year-old mother of 3 children, neonatal thyroidectomy done at Nagaland, referred for RAIU therapy. You can see there is plenty of nodes here and there. You can see. And then is a small node again recurrence. You can see these tiny nodes should have been taken at the time of surgery, but anyway, so that can be taken. This patient had also a rising thyroglobulin after a few months when it came. There was a node even in the axilla. You can see there is axillary metastasis because these are the second line of retrograde flow of metastasis to the axilla. So thyroid imaging in thyroid carcinoma, you can have different good old days, thallium, EB, tetraphosphine. Nowadays it is FDG and Dotanoc, and if it is radioiodine refractory, we are doing now FAPI scan. So this is a 29-year-old female presented with a headache, and then somebody did a MRI. They found a cerebellar meningioma. Patient gadolinium scan. Patient was sent for surgery on neurosurgeons sent them tissue. It was a vascular mass and turns out to be metastasis from papillary thyroid carcinoma. Prompt thyroidectomy was done after the neck dissection, after the meningioma, so-called suspected meningioma, and then there was no iodine concentration. This was FDG PET scan. You can see the head to toe metastasis at the time of, she is just 29 years. If you take all the example, you all will be considered as a classic low risk, but still we need to modify our low risk criteria. The ATA is trying to find out further, refine the low risk criteria. You can have a gallium dotanox scan and you can give lutetium dotatate. You can treat this patient metastasis, and we have now treating this patient with FAPI. We have initial paper on FAPI pilot study, and 15 patients was published on the cover page of Thyroid. And now we have 73 patient data, long-term outcome, just published in February 2025. So this is another modality which you can use it for treating the radioiodine refractory thyroid cancer. And then we have got medullary thyroid carcinoma, which can be picked up by Dotanox scan or can be picked up by FDG. And you can now do the FAPI scan. If in this patient had MIBG positive, so we treated with MIBG, this medullary, very rarely MIBG positive in medullary, about 5 to 10% only. But this patient was luckily was MIBG positive, so we give the MIBG treatment. So this you can sometimes in a 37-year-old male diagnose, this is a patient who had referred from endocrinology department, suspected PO, and we did a MIBG scan. We found there is bilateral. Whenever you see a bilateral PO, you must suspect syndromic. And we something saw in the neck. Actually, this is a MEN 2A patient, which has been missed. This was a medullary thyroid carcinoma, which has been positive and detected reverse way. So this patient was given Dotanox scan, you can see, and MIBG. Thank you. If any other question, I will be happy to answer.
Thank you, sir. Thank you for covering whole aspect of indications for nuclear scan in the era of ultrasound and CT scan. There is one question from the audience. They have asked in a post-op case of papillary thyroid cancer, post-radioiodine ablation, but anti-thyroglobulin levels are high. So what does the raised anti-thyroglobulin signify and how to follow?
Yeah, we have a very classic paper from Martin Schlumberger, you must have, and there is another paper from Furio Passini from Italy. They are in Europe, they are the opinion leader of the good old days. And they have a classic paper demonstrating that normally if there is no remnant tissue or there is no distant metastasis, the anti-TG antibody takes around 36 to 38 months, the median time to come back to normal, unlike thyroglobulin. So you have, if there is no structural lesion, So you cannot, you just not jump and give hundreds of millicurie. Just wait. If you look at the downward sloping of the thyroglobulin, antithyroglobulin antibody, and just to keep the patient, if they are low risk, you can keep the TSH between 0.5 to 1. If it is intermediate risk, you can give 0.1 to 0.5. See the direction of the anti-TG antibody. If the anti-TG antibody is going slowly down, I have seen patient after 3 years totally disappeared. If it would have been given iodine, I would have taken the credit for not doing wonderful thing for the patient, but the patient was being cured by his own body's mechanism. It is the time it takes to drop from very high concentration to normal. It takes. Now the new assay also, it is the upper limit is only 4.5. The good old SIP, RBC SIP method was taking 125 was normal, but now it is 4.5. You are more accurate method, and you can follow these patients over the time and see.
Thank you, sir. No further questions. Thank you for your excellent presentation, sir. So we move on to the next aspect of the quiz. So I'll just go through the rules of the quiz in short. To participate in the quiz, click on the button, attend quiz button, given on the screen, which is being live streamed. So there will be attend quiz button. The quiz will be conducted through a platform called Slido. You're requested to use a laptop for ease of experience. Quiz will run for 5 minutes. The quiz master will display case or description of question by screen sharing a PowerPoint file. There will be 10 questions. Each question will be available only once for 30 seconds with the timer on. Kindly do not refresh the page or go back onto the page. So to conduct the quiz, we have Quizmaster Dr. Anusha Nadik, who is consultant endocrinologist at Fortis Hospital, Bangalore. She has presented multiple posters and papers in national state levels. Over to you, Dr. Anusha.
Thank you for that kind introduction. So hope the rules are clear. Shall I start sharing the screen?
Ma'am, wait for 2 to 3 minutes.
Okay.
People have to join on the platform.
Sure, no problem.
You can share the screen.
Yeah.
And then, once they give the go ahead, then you can start the quiz.
So my slides are visible?
Yes, you have to go to the full screen.
Yeah, I'll do that. So slides are visible, right?
Yes.
Yes.
And am I audible?
Yes.
Yes.
Okay, fine.
Ma'am, as of now, about 8 people have joined. We'll wait for 1 more minute. I'm thinking more people are there. Yeah, let
Sure.
them join. Because the moment we start, we will not be able to continue.
Yeah, no problem. Just let me know when I should start.
Yes, ma'am. Yes, ma'am.
Yeah.
1 more minute and we'll start. Yeah.
Sure.
Ma'am, I think we can start now, ma'am.
So today I'll be conducting the quiz for postgraduates. So before without wasting time, we'll start. So coming to the first question, all are true about glucose metabolism and hypothyroidism, except insulin resistance is common in hypothyroidism. Reduced glucose stimulated insulin transport is failed is a feature of hypothyroidism, that is altered GLUT2 translocation. In hypothyroidism, there is reduction in GLUT5 expression in skeletal muscle, and metformin increases TSH.
Next question.
So the second question is the recommended dietary allowance for iodine in pregnancy and lactation. Is it 150 microgram per day and 200 microgram per day, respectively? 170 to 20 in pregnant and lactating women, respectively. 200 microgram per day and 250 microgram in pregnant and lactating women, respectively. 220 microgram per day and 290 microgram per day in pregnant and lactating women, respectively.
Next question. Next one. Next.
So all are causes of truly refractive hypothyroidism, except malabsorption syndrome, disturbance in assay, renal or liver function impairment, hypercortisolemic conditions.
Next.
Which of the following is not a recognized feature of methimazole embryopathy? So conal atresia, pulmonary hypoplasia, tracheoesophageal fistula, aplasia cutis.
Next question.
So a 40-year man with Graves' ophthalmopathy who has started treatment with teprotumumab. After 4 infusions, patient improved, but patient complains of tinnitus and hearing loss. What will be the next management? Whether to increase the thyroxine dose here, whether to perform MRI brain, whether refer to oculoplastic surgeon, refer to ENT surgeon, or we can start selenium or steroids.
Next.
The dose of radiotherapy recommended in Graves' orbitopathy, is it 10 grain single fraction, or it is 5 weekly for 4 weeks, or 20 grain 10 fractions for 2 weeks, or 30 grain 15 fractions for 3 weeks?
Next.
Which of the following tests helps to differentiate TSH-HOMA from resistant to thyroid hormone? Is it anti-TPO antibody, thyroid profile, TRH stimulation test, serum thyroglobulin?
Next.
So, 42-year lady with persistently high TSH. Initially, it was 9.6 and FT4 was 1.2. She was started on thyroxine 50 mcg and dose was increased, but still the TSH did not come down. The compliance is good, but still TSH is 8.8 and FT4 is 1.8. What is the most probable diagnosis here? Is it macro TSH, malabsorption syndrome, heterophil antibody interference, or resistant to thyroid hormone?
Next.
So, which gene mutation is strongly associated with papillary thyroid carcinoma? Is it RAS, BRFA, RET, or PAX8?
Next.
So, coming to the last question, which of the following is true regarding immunotherapy-induced thyrotoxicosis? It usually presents within 6 weeks of therapy, usually presents within 6 months of therapy. ETA recommends monitoring TSH and FT4 at least every 12 weeks during treatment. It is commonly due to Graves' disease.
Thank you, ma'am.
Thank you.
Thank you, Dr. Anusha. I think we can discuss the answers to the DM quiz.
Okay.
And meanwhile, the tech team will collate the winners and we can announce the winners at the end of the discussion. So you can go through the answers of the DM quiz first.
Okay. Yeah. So, when it comes to relationship between glucose metabolism and hypothyroidism, the insulin resistance is a known factor. The hypothyroid patients, its answer is, one second, I'm sorry.
The
Yeah.
slide has not come.
Is it okay now? The first question was between all are true about glucose metabolism and
Let's
hypothyroidism.
go to question number 1.
This is question number 1 only, sir. Am I?
No, it is showing question 10.
Slide is not, I think you have to share the slides.
Okay.
I think you put on screen full screen and then you go to 1 number. You're still on 10.
Okay.
I think you share the presentation with the answers.
The presentation is showing up, but she has to put it on full screen.
Is it okay now?
It is still showing question number 10.
Okay,
You stop the share and share it again. That's the best way.
Yeah.
Yeah.
I'll do. One second. Are you able to see, ma'am?
Yeah.
Yes.
Yeah.
Go
Just
to
make
full
it full
screen.
screen. Full
Yeah.
screen.
Okay, so the first question was the glucose metabolism in hypothyroidism. The answer is D, which is metformin increases TSH. That is the wrong answer. The metformin actually decreases TSH. In hypothyroidism, there will be insulin resistance, one of the feature. Along with that, there will be reduced GLUT2 and even GLUT5, though it is not common in skeletal muscle, even that expression is reduced. And metformin, whenever we are starting in subclinical hypothyroidism and PCOS or in diabetic patient, that actually decreases the TSH. There are few mechanisms for that. They tell that it involves the AMPK pathway, and that in fact increases the thyroid sensitivity at the central level. These are the theories, I mean, the explanation they have given. The metformin actually decreases TSH. So the second question was recommended RDA for iodine in pregnant and lactating women. The answer is it is 220 and 290, which was the option D again. So the recommended RDA is 150 in adult microgram per day in adults, and 220 microgram per day and 290 microgram in pregnant and lactating women respectively. Coming to the third question, which is the causes of truly refractive hypothyroidism, the answer is B. So again, there is a pseudo refractory hypothyroidism and truly refractory hypothyroidism. These are the causes of pseudo refractory. So sometimes we miss the diagnosis, I mean, incorrect diagnosis of the disease, and sometimes they will be taking some other medication with thyroid medication. They won't be taking it properly, the compliance issue. So these are the pseudo causes of refractory hypothyroidism. And when it comes to truly refractory hypothyroidism, when they have malabsorption syndrome, it could be gastroparesis, lactose intolerance, inflammatory bowel disease, short bowel syndrome, anything related to the GI, and or in someone who has impaired renal or liver function, they can also have decreased peripheral metabolism of T4 to T3, causing decreased T3 level, which is again difficult to optimize the dose in such patients. We all know that glucocorticoids usually suppresses TSH by acting at the hypothalamic level, and in Addison's also, we have to, the TSH can be slightly on the higher side. So whenever we are treating hypothyroidism, especially when it's central and especially when you're suspecting adrenal disease, you have to rule out adrenal insufficiency before you start thyroxine. So coming to the fourth question, the question here was the methimazole embryopathy, all are included except. The answer here is B, that is pulmonary hypoplasia. So all of us know that in first trimester we prefer PTU. The reason here is the methimazole or carbimazole can cause embryopathy. That includes esophageal atresia, tracheoesophageal fistula, aplasia cutis, and even corneal atresia. So because of that, we prefer PTU. Though PTU can cause fulminant hepatic necrosis, because of this side effect, we prefer PTU in the first trimester. We change it to the methimazole or carbimazole during next trimesters. So here, we patient 40 years man who was on teprotumumab. After starting treatment, patient developed tinnitus and hearing loss. The answer here is we have to refer to ENT surgeon. So we know, that this teprotumumab is the a newer treatment for the Graves' orbitopathy. It's a insulin-like growth factor receptor inhibitor. It was a first drug approved for the thyroid orbitopathy treatment. Based on the OPTIC trial, actually there was improvement in the proptosis by 2 mm, and even the clinical activity score had improved. So recently, when they saw this long duration or the long-term effect of this drug, they saw this hearing impairment of one of the side effects they have seen in this group. And hyperglycemia is second most common. So this should be considered, and someone develops this, the patient should be referred to the ENT specialist. So the dose recommended in Graves' orbitopathy is it's 20 gray in 10 fractions. That is the recommended dose. The answer is C here. So according to the guidelines, they are supposed to take the 20 delivered in 10 fractions over 2 weeks. But few studies have given lesser dose and still they have seen the effect. But the recommended dose is 20 gray delivered in 10 fractions over 2 weeks. So when it comes to the clinical, sometimes this confusion comes that to differentiate between TSH-HOMA and resistant to thyroid hormone. So the test helps to differentiate between these two is TRS stimulation test. So when you have to differentiate between TSH and TSH-OMA is pituitary tumor adenoma, which is secreting extra TSH, and resistance, your body tissue will be resistant to the thyroid hormones. The presentation wise, they can have hyperthyroidism with visual features because it's a pituitary adenoma, and they resistant to thyroid hormone can have normal or mild hyperthyroid features. Both of them can have goiters, and thyroid hormone both will be elevated and non-suppressed TSH. Here, to differentiate it, the MRI definitely shows pituitary adenoma, and genetic test will show the 90% of the mutation in TSH beta, rarely in alpha. The TRS stimulation helps to differentiate between these two. When you do give TRS and IV and recheck at 0, 30, and 60 minutes, the response will be extensive in resistant to thyroid hormone compared to the TSH-OMA, which is pituitary adenoma will be autonomously secreting TSH. The response will be only with that high compared to that resistant thyroid hormone. And we can also do T3 suppression test. The inhibition where that inhibition can occur in resistant thyroid hormone compared to the TSH-OMA, where there will be autonomous secretion of TSH. So coming to the next question, where 42 years lady who had persistently high TSH, even after increasing the dose, TSH didn't come down. And FT4 had gone up from 1.2 to 1.8. Here the diagnosis is heterophil antibody interference with TSH. This I think in the beginning, Sir was discussing about this. In scrub typers, there was antibody interference, and that actually we should consider. So this hetero, you can see here, the malabsorption is ruled out because FT4 has increased from 1.2 to 1.8. Only the TSH is, on the higher side. We should consider this when there is clinical and laboratory values are not correlating. So the antibody, sometimes it can be physiologically present in 10% of normal population, or sometimes infection, or even antibody. The heterophil antibodies, the endogenous antibody will be interfering with the immunoassay. So this we can decrease by doing another platform or another manufacturer. Sometimes serial dilution also might help. So strongly associated mutation with papillary thyroid carcinoma, the answer here is BRAF. So whenever we have, especially in the thyroid 3, when I have confusion, we can go for molecular testing. And this BRFA is one of the most common mutations seen in papillary thyroid carcinoma. Here it will tell us the prognosis if this is positive. If it is positive, it's more aggressive tumor. The lymph node metastasis and extracellular infection invasion is common, and the recurrence rate is also common with this mutation, and the treatment failure and mortality is also high. So which of the following is true regarding immunotherapy-induced thyrotoxis? The answer here is which presents within 6 weeks of therapy. So immunotherapy-induced thyrotoxicosis or thyroid problem is most common endocrinopathy we see on day-to-day basis. Here most commonly there will be destructive thyroiditis. Initially they'll have thyrotoxicosis, and then they'll end up with hypothyroidism. So when someone who is on immunotherapy, your ATA recommends that you are supposed to monitor thyroid function, and for the symptoms of thyrotoxicosis or hypothyroidism every 4 to 8 weeks. And once when they are on therapy, when they stop the therapy, you're supposed to monitor every 3 to 6 months. The treatment is very simple. When patient is on thyrotoxicosis stage, we need not do anything. You can use supportive treatment like propranolol. But when patient goes to hypothyroidism, we can start with thyroxine. So usually it begins within 6 to 10 weeks after treatment, but it can come as early as 7 days. Thank you.
Very nice cases and very interesting educative. I have got 2 comments. One is about teprotumumab.
Yes,
in 9 out of 41 and 2 out of 20. I think, have you done a chi-square test and found their statistical significance? Because in control, which are nothing to do with antibody, there are 2 out of have got hearing problem. So have you done the chi-square test and found it is statistically significant?
It was not statistically significant, sir, but that was the common side effect they have observed.
No, it's
I
okay.
just
But if
wanted
it is also seen in the control. So that is why you have to
that
do a
is what the
statistical significant one. Second question is, all the thyroid carcinoma are now classified into RAF type or RAS type. So
That
there
I
is A, B, C, D. B, RAF is the commonest one. That is RAS type and RAF type. There is genetic signature in it. That is why you have to do that. And you described all these bad prognostic is not that. 98% of the papillary thyroid carcinoma is Korea. It has got BRAF
No,
positive.
sir, I
So
just wanted
it
to.
was one group in America that they highlighted BRAF, everything they published in Science, Nature, and everything. And now the ATA guideline says only if your BRAF is positive, only risk factor is only 2%.
I know, sir,
So
but
that's why it is. If it would have been all the Korean would have been dead. If the BRAF mutation positive and your thyroid cancer, then 98% Korean would have been dead. So it has nothing to do. For
okay,
your
sir.
information, for the education of the student, I am telling you, BRAF presence only shows that there will be iodine resistance. That's
Okay, sir.
otherwise very nice cases, very educative.
Thanks.
And this iodine recommendation is by is changing earlier or now the recent most, because these numbers goes on keep changing from decade to decade.
So it was taken from 2022, I guess.
This is National Institute of Nutrition recommendation or Central Government of India recommendation. What is that?
This is, taken from
Because you have
the.
to give always reference which you are quoting.
Yes,
Because
once
the
again.
park and park will have say different numbers, then will have NIN will have different number, somebody will have a different number. That's why you have to, whenever you recommend numbers particularly, you have to, because most of our questions in India, multiple choice questions are more of memory based. You know this or not? Because if you read the USMLE questions, it is only one paragraph. You have to find out the answer in that. Don't try to memorize things. But most of the Indian, because as a dean examination, I am seeing, I just collected 1,000 questions and 80% of them are all memory based, which USMLE would have rejected them, all of them.
Thank you, sir. Tech team, we have the results. Bashir?
Tech team, are you there?
Yes. Okay.
Yeah.
So I think congratulations to the winners. First prize goes to Sri Vaishnavi. She scored 6 out of 10. And the second one is Dr. Nikhil Sanjeev, 5 out of 10. And San, 5 out of 10. I congratulate all the winners. They will receive a certificate of appreciation from ITS through EAP. So, Dr. Anusha, we can just discuss in short about the practitioner's quiz questions.
So my slides are visible, sir?
Not yet.
No, Anusha.
Not yet. I have to reshare, I guess. Is it visible now?
Yes, now it's good. Yes.
Yeah.
Go to full screen.
Sure. So,
And discuss in short. Yes.
coming to the practitioner's quiz, the first question was about thyrotoxic periodic paralysis. So what is true among all are true except. So the correct answer is females are most commonly affected. The thyrotoxic periodic paralysis is commonly seen in men. So they say testosterone has some role in that. So it's usually present in the 2nd to 4th decade of life, and they'll have thyrotoxicosis symptoms. The Hoffman syndrome refers to the answer here is muscle hypertrophy with hypothyroidism. This is seen in someone who has severe hypothyroidism. They'll have, it's a rare and specific form of hypothyroid myopathy that is characterized by proximal muscle weakness and pseudo hypertrophy of muscles. So again, the same question I have, like I had put in a different form, which is metformin effect. Actually, it decreases TSH. And the cutoff of tertiary hypothyroid during pregnancy. So according to this thyroid article published, that is 4. And if T4 should, I mean, you can take up to 1.5 upper limb of the normal in a pregnancy state. And chronic amiodarone therapy and the mechanism here, that if it causing hypothyroidism, what is the mechanism here? The answer is B, Wolff-Chaff effect. Here has a protective mechanism because of high iodine in the amiodarone that actually decreases the T3, T4 production. And most of the time it escapes and thyroid profile will become normal. But when someone who is prone for hypothyroidism or Hashimoto's, they'll end up with hypothyroidism.
This is otherwise called thyroid constipation.
Yeah. So this is, I mean, since I had seen in my clinical practice 2-3 experience, I had put this question. 21-year-old female presented with galacturia and prolactin was 51 and MRI pituitary was showing enlarged with TSH high and low T4. So what is the diagnosis here? So diagnosis is very simple, primary hypothyroidism. So because of increased TSH, there will be thyrotrope cell hypoplasia and can appear as a pituitary macroadenoma. That should be kept in mind, especially when TSH is very high. That's what I wanted to tell. And this Birch-Revsky score for the evaluation of thyroid SCORM includes except. So it includes temperature, cardiovascular dysfunction, gastrointestinal hepatic dysfunction, and central nervous system disturb, and additional any precipitating factors. If the score is more than 45, it is thyroid SCORM. It is between 25 to 44, it's impending SCORM, and if it is less than 25, it's unlikely. So subclinical hypothyroidism, and most of the time, like, you know, that this question, I mean, in clinical practice also we see a lot. That's why I included this. So where the treatment is strongly recommended, the answer here is pregnant lady or planning for pregnancy. Subclinical hypothyroidism, if it is again less than 10 or more than 10, it's, I mean, you can consider treatment. And if someone has symptoms of hypothyroidism, then also you can consider treatment. Goiter or positive TPO antibodies, we can start treatment. The woman who is planning for pregnancy, who is having irregular cycle, or who is that patients also can be considered treatment. So pregnant woman in first trimester with TSH is 0.1 and normal T4, what is the next best step? So here the monitoring thyroid function without giving treatment. So gestational thyroid toxicosis is a transient phase, usually in the first trimester. And all of us know that it's because of increased thyroid stimulation by HCG. And it's it's physiological and we not treat that, we can wait. And so which is the following is the most important to assess before starting levothyroxine in central hypothyroidism. So it's cortisol. If someone is suspecting central hypothyroidism when there is low T4 and normal or high TSH, slightly high TSH. So whenever you're starting medication for central hypothyroidism, it's always important to rule out adrenal insufficiency, because when you start a thyroid medication, there will be increased metabolism of cortisol again, and they'll end up with adrenochromatosis. So it's important to do cortisol. Thank you.
Thank you, Dr. Anusha. Can we have the results of the practitioner's quiz?
Yes, sir.
So the practitioner's quiz winners, first prize goes to Dr. Sheetal Bodke, second prize Dr. Swati Dole, and third prize to Dr. T.S. Prabhuram. Congratulate all the winners. You will receive a certificate of appreciation from the ITS through email. Over to Dr. Gani.
Yes, sir. So thank you, Dr. Anusha, for conducting a very interesting quiz, as Dr. Bal sir and Dr. Reddy sir rightly said. So as we come to the end of today's session, I'd like to invite Dr. Pramila Madam to share her closing remarks.
Yeah, thanks, Dr. Gandhi. So today we had a really interesting discussion, starting from the cases presented by Dr. Kunal and moderated by Dr. Sriram Mahadevan and Dr. Vaishali Deshmukh, and an excellent talk by Dr. Bal sir. And we all had a lot of new insights into a lot of things, and we came to know with many new things and many more information from his talk. I think it was very good for the residents, and I think because we will have a recording of this, so if the residents want to watch it and listen to it again, they can always do that. And I also thank Dr. Anusha for the excellent quiz. And we had a nice discussion on the quiz questions as well. So I hand it to Dr. Gandhi to go for to tell about the World Thyroid Day, which we will be doing on 25th. And that we will be having a webinar online CME from 11 to 1. So Dr. Gandhi will just share the details and the next thyroid clinic for the next one.
So our next thyroid clinic session is scheduled for the June 11th. But prior to that, as ma'am said, we will have the World Thyroid Day webinar on the 25th of May. So there will be international speakers as well who will be talking on different aspects of thyroid diseases. The focus of the webinar is on thyroid in women, and hence the session will include thyroid at puberty, pregnancy, osteoporosis to cognition as well. This will be followed by an interesting panel on approach to thyroid nodules in pregnancy, followed by a quiz as well. So, before we conclude, I request the tech team again to display the QR code. So where those who are interested to submit their research for the flagship journal, that is the Thyroid Research and Practice, can do so by scanning the QR code displayed here. And those who are interested to become a reviewer for the Thyroid Research and Practice again can do so by scanning this QR code. So we hope this session with discussion on challenging scenarios related to the thyroid assays and also the role of nuclear medicine in the management of thyroid disorders and the quiz definitely has been valuable and informative to all. So, and we hope all of you can join us again on the enriching sessions on thyroid health on the 25th of May and June 11th as well. So to conclude, thank you all for joining, and we hope to see you on June 11th and the 25th of May. Thank you. Thank you, one and all. Good night.
सर्वमिदं विभाति